to continue with our next speaker because he's very excited and he's very exciting. So looking forward for everyone to hear what he has to say. So Dr. Abdulrahman Fadil, he's from Baghdad. He finished his university at 2008 and he did a lot of practical training. And afterwards, he joined the Professional Cosmetic Diploma in 2016 in Baghdad. And not only he's part of the Baghdad Smile Center, where he's practicing his aesthetics crafts, but he's also part of the training center. So he's part of the scientific committee where he developed his passion for teaching, which is something that the Bird Academy helped me personally a lot. And I'm sure all of these young graduates and speakers today, we all needed a little bit of a notch from our great experienced lecturers to help us to be confident in our work and to make sure we present it in the right way. So, Abdulrahman, are you with us?
Yes, I'm with you, and I'm also proud of you all.
Thank you for joining us. How is Bahrain? Are you there now?
What?
Are you back home in Bahrain?
Yeah. No, I'm in Iraq.
So how are things there?
Yes, good.
Everything good? Family
Everything.
keeping safe?
Yes, all are good.
Are you practicing or you missing dentistry?
Now, little bit. I'm missing dentistry, but in the future, inshallah, we will return everything. I think from tomorrow we will start slowly for dentistry, inshallah.
Hopefully. Okay, mic is yours. Good luck.
Thank you so much. I'll start to share my screen.
Yes, if you share your screen, Doctor.
Assalamu alaikum, everyone. The screen is okay now, Dr. Hassan.
Perfect.
Yes, thank you so much. So my lecture will be about the conservative adhesive teeth preparation. I'm sorry, there is a lot of topics in my lecture, and I'm really shocked because I heard some lecture of my colleagues before me. They only speak about the single or double cases. It was for me a shock. So no problem, I'll try to summarize everything, and I'll concentrate my lecture about the clinical work and the clinical cases, all supported by references and evidence-based dentistry. So my name is Abdulrahman Fadil. I'm graduated from College of Dentistry of Baghdad University at 2008 and master degree 2017. I'm working in a governmental center. It is Al Karama Specialized Dental Center with a newly graduated training dentist. And always we are sharing our information and enjoy our time and sharing our seminars and make nice presentations and case reports all the time. So my private work is at the Baghdad Smile Dental Clinics with a very nice team and very nice administration, and we always try to be better and better and better. With Baghdad Smile, I have a chance to learn and to attend a lot of courses, advanced courses with a big hits in cosmetic dentistry, conservative dentistry, like Dr. Talal Nahlawi, greeting from Iraq, Dr. Talal Nahlawi, and also Dr. Victor Sherbakov. He was a very good dentist in composite restoration. I learned a lot from him. Also the star Muhammad Hammo, the big star of Bird, Muhammad Hammo, I learned a lot from him. Also, I'm always invited to many TV programs relating to oral health, aesthetic dentistry, etc. I'm also a lecturer in many events, conferences, learning courses in Iraq, in many cities in Iraq, like in Karbala, Nasiriyah, and Maysan, and also in Erbil. Now, my last course was in Japan with the Tokuyama Dental Company, which was about advanced anterior and posterior composite restoration. But to be honest, my real change in my life as a cosmetic dentist, this is my family, my wife and my little boy and sister and daughter, sorry. The real change in my life as a cosmetic dentist was in 2016 when I finished the course of Baird. With Baird, I understood a lot of things that were difficult for me in the past. I learned how to document my cases, how to share my cases, how to present my cases, and in fact, I can bridge the gap between me and the lab technician and a lot of things. Thank you, Bert. Thank you, this academy. Thank you, my second family, my second always nice family, we are always hope a new advanced courses from Baird to share and to be in the future. So my lecture will be about the cavity preparation. I'll start with adhesive dentistry. Modern concept in restorative dentistry, which is concentrate on minimally invasive dentistry, which is more aesthetic, longer lasting, and we have a lot of treatment option. So the most important thing is more conservative cavity or teeth preparation in general. So I'll try to summarize my information because it is too much for this small time or little time. So we have a basic consideration in adhesive preparation in cavity preparation. First thing is the preparation should be as conservative as possible. As we can see here in this cavity preparation, this is class 1 and class 2 only the box design. Okay, the second thing is we must always protect the adjacent tooth. Why? Because there is a lot of papers and articles and researches that support that always there is a damage to the proximal wall of the adjacent tooth. So we must always protect the adjacent tooth. We must use the wedge band or the fender wedge to protect the adjacent tooth. Another thing, it should allow for cleansable gingival margin. Okay, cleansable gingival margin. It should not include any sharp internal line angles. Okay. No adhesive restoration without rubber dam. No adhesive restoration without rubber dam. Because anyone not work under rubber dam, he will prevent himself to enjoy his work. There is a lot of the enemies inside the patient mouth, like saliva, blood, patient tongue, patient cheek, and the noisy words of the patient. We can all prevent that by using the rubber dam. Okay. For anterior restoration, I have something maybe different from Dr. Hadi that previously mentioned a lot of nice information. So for anterior restoration, we must extend our cavity according to the size, shape, and the location of the defect. So we have no design for the cavity in the anterior restoration except we follow the caries. The caries, fault, any old friable tooth structure should be removed, and removal of the discolored tooth structure for the aesthetic. In case of the patient want to change the color of his teeth and we have a discoloration for one tooth, we want only to mimic the adjacent tooth as Dr. Hadi mentioned before. Okay. Enamel reduction is required. Why? To improve the bone strength. Because a lot of papers support that the unprepared surface of the enamel, which is a prismatic surface, offer only minor retention capacity. So always we need to prepare the enamel for the anterior teeth. What about the retention? No need for retention, mean only we need etching of enamel or sometimes enamel and dentine, and then we do bonding that upon polymerization micromechanically interlock to the created porosities by acid etching. Do we need these pins? No need for these pins. It is a matter of history. Okay. What is the advantages of the bubbling? Always we use it by flame bear or by using a long tapered fissure bear. Increase the enamel surface area, thus strengthening the restoration. Also for the aesthetic, by developing an even color transition zone, eliminating the line of demarcation between the tooth structure and the newly composite applied restoration. Another important thing for the bubbling is the ends of the rods are etched for improved bonding. As we can see here in this photo, if we didn't make the bubble, the enamel rods will be less than with bubbling. Okay, as we can see here in these clinical cases, this class 4 missing incisal edge with the proximal surface. So we always do isolation with rubber dam, but not balloon. We use rubber dam. And we do beveling and etching and palatal shell and then a proximal surface, and then we end up with the layering, and this is the final case, and this is the case after 1 week recall. Okay, we can see the chameleon effect is very good, and the color transmission is very good, and everything was good, and the patient was happy, and he asked me to change the composite filling restoration of the adjacent central incisor, but the problem was he will not come later. Okay, another clinical case, we have a chipping incisor, central incisor, incisal edge of the central incisor. Everything we do is the beveling, isolation, etching, and we protect the adjacent teeth by Teflon, and then we did our bonding and layering, and we did some characterization to mimic the adjacent tooth. This is the case after, and this is the case before. The same story with all anterior restoration. We have here an old restoration, composite restoration for a lateral incisor, peak-shaped lateral incisors with previous failure, composite restoration. We remove the restoration and we remove this pin, and then we did our cavity in the same way. We did beveling, we did isolation, and then we did our etching, bonding, and then we finished the case in this way. Sorry, the patient didn't come for the follow-up photo, but this was the case after we finished our work. Okay, let's shift now toward the diastemic closure. I know that the next lecture will be about the diastemic closure, and Dr. Sadir, greeting from me, Dr. Sadir, he will discuss everything. But the same story with diastemic closure, we deal with it as an anterior composite restoration. We just removed the old composite restoration and we did simple beveling for this case, and then we do isolation and acid etching, and everything will be done as any normal composite restoration for anterior teeth. Okay, this is the case after 2 weeks, and we can see the gingiva, how it migrate from here to close the black space. And this is the another view for the case. The case was for dentist also. Okay, what about the posterior? We must answer the question, which is why we use composite in posterior. The answer will be as the following. First thing is the aesthetic. You can see the big difference between the old amalgam restoration and the new composite restoration. Okay, second thing is conservative tooth structure removal and easier, less complex cavity preparation. As we can see here in these cavities, we have a lot of cavities here, but all are simple. No need to do extension for prevention. No need to do more cavity for such defect. It is more than enough to do our filling. Also, it is economics if we compare it with indirect restoration. Another thing can be repaired, which is impossible for amalgam restoration. Also, we have a benefit from bonding, which decrease the micro leakage, recurrent caries, and post-operative sensitivity. Another thing, it increases the retention and strength of the remaining tooth structure, which is the opposite for amalgam. How can we design the cavity for posterior? Nothing will be new according to this information. Nowadays, the approach of extension for prevention by G.V. Black in 1970s is no longer justifiable, but now it has been replaced by the concept of minimally invasive dentistry. Minimally invasive dentistry give us the chance to focus on the achievement of more conservative cavity design, providing sufficient access for complete removal of the carious tissue, and then the restorative procedure relies on bonding effectiveness of the adhesive materials. No need for old school. As we can see here in this cavity, the proximal cavity of this lower 5, it is very small and it is very conservative. Okay, let's see some clinical cases supporting this issue. We can see the difference between the old large amalgam cavity preparation and the new composite minimally invasive cavity preparation. We apply our matrices, and we do always selective edge universal bond, and then we convert the case from class 2 to class 1, and then we did our layering technique in this nice way, and this is the immediate result of the case, and we can see the case follow up after 3 months. Everything was okay, the contact was very nice, and the patient was happy, and nothing was disrupting the patient. Okay, another clinical case, we just follow the caries. Can you see the cavity preparation in this way? And in this way, sorry, this is a buccal cavities, no need to join everything. We must separate everything we do it. Selective edge always, and then we did our layering technique, and we can enjoy the result and follow-up visits. We can see the patient immediate, and this is the case 2 weeks recall, and this the case after 1 month recall. As it is, everything was good. We just followed the principles, and we did good isolation, and we did everything in the right way. This case may be the same, nothing new, but the difference here is the buccal cavity. So I did a love, because we have a love story with dentistry, of course, and this is the final result of the case. Thank you so much for Baird for this supporting information. I learned a lot from you. If we are dealing with a deep margin, how we deal with a deep margin? I classified the deep margin into 3 lines or 4 lines. The first line is a shallow margin. We can push the gingiva by using pre-wedging technique. We just apply a wooden wedge in the sulcus to push the gingiva, and we can work easily and finish our work. If we are dealing with a deeper margin, we must go to the second line, which is the pushing, using of the retraction cord. I prefer from Ultradent retraction cord. It is very nice product. And we push later the rubber dam inside the sulcus to ensure the cervical seal. As we can see here in this photo, we push the rubber dam here. Then we finish our work and apply our matrix in the same way. The third line is the DME, the deep marginal elevation. This concept, if we cannot push the rubber dam inside the sulcus and still there is a gingival tissue, we can use the deep marginal elevation by the application of Toffoli-Meyer matrix or modified Metafix matrix, and we do coronal elevation of deep margin by using direct composite restoration. And then the second step will be the application of direct restoration or indirect restoration. This will facilitate our work and ensure perfect cervical seal. The fourth line is the gingivoplasty. If we can't get a good seal for the margin in these three first lines, we go for gingivoplasty, but we must always respect the biological width. If there was any problem with the biological width, we always refer the case to the periodontist to do crown lengthening. But if we can do gingivoplasty, we can use the laser or special burr, which is a thermocut burr, and then we make a hemostatic agent using a special hemostatic agent, and it is amazing from Ultradent, which is Astringent X. Okay, this is one case that I use the same story. I'm sorry if the video was not good. I tried to do my best to show you how can we make gingivoplasty using thermocut burr. And after that, we can use the hemostatic agent, as I mentioned before, Astringent X from Ultradent. Thermocut is from Dent Supply. It is very good and it is cheap, and everyone can use it if have no laser device in the clinic. In this way, we will get very, very dry field, and we can apply our restoration in a very simple and nice way. Another clinical case relating to deep margin, this case with a class 2 lower 6 for young patient with little bit poor oral hygiene. We did a pre-wedging technique, and we always protect the adjacent tooth by using fender wedge, and then we did our restoration with dry field. Can you see this, the gingivitis that is present in the patient? After that, this is the 3 weeks recall. We can see the gingiva become little bit healthy, but after 8 weeks, everything was okay, and the case was perfect, and the patient has no complaint from anything related to gingiva. Okay. What are the new considerations related in minimally invasive root canal treatment? This is maybe controversy, but all my information supported by references and very nice papers, but we have no time to mention everything. The first thing, for almost century, all endodontic textbooks taught us to expose the pulp chamber with a straight line access to the orifices of the root canal system. But with this era of enhanced lightening, magnification, we have super flexible rotary instruments, this approach being questioned. Okay. The second thing is maintaining the structural integrity of the pericervical area of the tooth is critical to their long-term survival and function, because all theses supported that no man-made material or technique can compensate for any missing tooth structure that lost during these key areas. Okay, another thing is the endodontic excess opening themselves have only small impact on the tooth stiffness, about 5% only, while the MOD preparation reducing the cuspal stiffness by 63%. All this support a new concept in endodontic treatment. For There is currently an abundance of studies in human teeth showing that the dentine properties of endodontically treated teeth do not differ in any meaningful way from the vital dentine. So treated molars with a maximum structure remaining can be restored without a crown placement with a fair long-term survival. Okay, another thing is the metal posts do not reinforce the tooth. We always use the fiber posts and used fiber post because it is more aesthetic, and retaining the tooth structure is more valuable than the use of the post where adequate structure are exist. I'm sorry, I think we have no time, but I can show you some access opening, modified access opening from the buccal side. As we can see here, everything was accessible, all canals. Also, we have proximal access opening for this lower 5. We have labial access opening for this central incisor. Also, I can use this clinical case, lower canine access opening from mesial part, and this is the master cone evaluation, and this is the case post-operatively. All the root canal system was covered, and this is the case after we finish the composite restoration. I'm sorry, I think the time will not support me because I have a lot of topics. I have only the final topics, but I'm sorry, I can't discuss everything. Thank you so much for nice attention, and I'll be more than happy to hear if there was any question.
Thank you, Abdulrahman. It was a beautiful presentation. You tried to cover so many things in such a short time, and thank you so much for all your tips and hints. I really enjoyed how you fixed the chipping in the centrals, and honestly amazing work. Well done.
Thank you so much.